This is Coronavirus House Calls with Dr. Anthony Fauci.
And across the nation, all 50 states have now reopened in some capacity. But the coronavirus pandemic continues to claim the lives of fathers, mothers, family, friends, and co-workers. COVID-19 has changed life as we know it, and the fight is far from over. That's why we're here to separate fact from fiction in this Nexstar digital original Coronavirus House Calls. I'm Art Franklin. And this Saturday, we're bringing you a special edition of Coronavirus House Calls. In studio with me is our leading panelist, Dr. Michael Sag, and it's so good to have you with us, Dr. Sag.
It's great to be back and great to be in studio with you, Art.
Yeah, Dr. Sag, as you know, is a prominent HIV/AIDS researcher, as well as the Associate Dean for Global Health at the University of Alabama at Birmingham. He's also the director of UAB's Center for AIDS Research and is an expert in the field of infectious diseases. And joining Dr. Sag and me today is the nation's top infectious disease expert, Dr. Anthony Fauci. Dr. Fauci is the director of the National Institute of Allergy and Infectious Diseases and has held this role since 1984. He has served under numerous presidents and is currently leading the nation's response to the coronavirus pandemic as a member of President Donald Trump's coronavirus task force. And we've received thousands of questions from our viewers from all across America. And today, Dr. Fauci will be answering those questions alongside his colleague, top doctor on coronavirus house calls, Dr. Michael Sag. And it's been a while since the two of you have actually been together. So we're going to let you guys go ahead and get acquainted. So Dr. Sag, so why don't you go ahead and start us off with the questions with Dr. Fauci.
Well, thanks, Art. And Tony, it's a pleasure to be with you this afternoon. Thanks so much. Before we get to our first viewer question, Tony, I'd like to ask you about your experience as a director of the National Institutes of Allergy and Infectious Diseases. What you've learned from the past infectious diseases, especially the epidemics that have emerged over the years like HIV, SARS, the 2009 swine flu, MERS, Ebola, and how has that sort of set you up to be in the catbird seat for the COVID-19 epidemic?
Well, thank you, Mike. That's a really great question because, as you know, because you've been with me through many of these intermittent challenges that we've had. And, you know, the lesson here is that in addition to the baseline of infections that you can predict morbidity and mortality of things like malaria and tuberculosis, you know, and neglected tropical diseases, they have emerging and re-emerging infections. This has occurred throughout the history of our civilization. They're occurring in the past, they're occurring now, and they will occur in the future. What we're experiencing right now with COVID is really a very dramatic example of what I guess you and I, Mike, over the years have always been talking about as our worst nightmare, namely a brand new infection that's respiratory borne, that likely jumps from an animal species to a human, and has the characteristics that I really feel are very challenging, as we all know, that is highly effective in its transmissibility from person to person and has a considerable degree of morbidity and mortality. And unfortunately, that's what we're living through now. So the lessons that we've learned through AIDS, through Ebola, through Zika, is that these things occur. They're different in many respects. They have different modes of onset. Some are insidious, like the HIV/AIDS outbreak was, when we didn't fully appreciate what the potential full impact would be, to something as explosive as what we're going through right now. It falls under the category of the inevitability of new emerging and re-emerging infections that we have to deal with.
Yeah, it is kind of like an unfortunate perfect storm and something, you're right, we've all feared. And that fear is translated to the public, and we address that through questions and answers like this. And so, Tony, our first question from a viewer is from Lucy in Madison, Connecticut, and she watches on TNH News 8. Lucy says this: going into this holiday weekend, what do you recommend for family gatherings? Should the visits be outside only? This will be the first time I've seen my grandchildren in months.
Well, that's a good question. But it really relates to the dynamics of the outbreak in the area that you are in. In other words, if you're in a situation where your community, your city, your county has gone past the guideline recommendations where they've gone through the gateway. They may be in phase 1 or even phase 2. The degree to which you have that freedom of interaction will really depend on that. So let me give you a concrete example. I live in the District of Columbia right now. I'm absolutely looking forward to the Memorial Day weekend for the reasons that I think everybody in the country are. We still have a high degree of infection in the District, Maryland, Virginia area. It's starting to come down, but it's still up there in the plateau area. So we have to be very more especially careful than a region or a county in which it's already going way down and the degree of activity is less. There are some minimum things you need to do. One is when you're in contact of a situation where you cannot maintain 6-10-foot difference, wear a mask, continue to do the hygiene things, washing hands, avoiding crowds, but don't hesitate to get out in the open air, to do as much physical separation as you can, but to enjoy it. I can tell you personally what I'm going to do. I like to power walk. I like to hike. I'm going to do that with my wife and my daughter and our dog, and we're going to go out. We're going to be having a mask on if we get close to people, but for the most part, we're going to enjoy it. If I were living in an area where there was very little infection at all, I might think about having a group of meeting with people of 5 or 10 people, getting together, sort of barbecuing as long as we stay separate from each other and wash our hands. But I'm not going to do that right now because of where I live. I'm going to do mostly get some good fresh air, enjoy hopefully some sunshine, but continue to separate myself from people purely on the basis of the dynamics of the infection where I happen to physically be.
Well, Dr. Fauci, it's good to know you're going to get out and enjoy this Memorial Day weekend. So a lot of people will be traveling by car and by plane to see family members and friends for the holiday. We don't have a vaccine yet. Is it safe for people to make those visits, and what should travel look like?
You know, again, it really does relate, Art. I want to get back. I don't want to be repeating myself, but I think it's important to do that because you've asked a very relevant question. It really depends on where you are and where you are going, because we have a big country. And if you look at the dynamics, which we do every day on the White House Coronavirus Task Force, look at the different regions, look at the plateauing and the going down. If you're going to an area that looks reasonably well contained, then I think you could feel very comfortable. The one thing that we want to keep emphasizing is that we need to protect the vulnerable, the people who are elderly senior citizens, particularly those with underlying conditions that we know so well, hypertension, diabetes, obesity. Those individuals have to have a very special level of care, particularly with regard to travel. So I would not recommend right now, virtually anywhere, someone who has an underlying condition superimposed upon age to be doing any airplane traveling right now. I would think you'd have to be very circumspect unless you had a very good, compelling reason, family compelling reason to do that. So again, it varies from where you are, what your demographic group is, and what the dynamics of the outbreak is in the particular area that you are.
Tony, so this question is a perfect follow-up to what you just said, and it's from Lenora in Oak Cliff, Texas, and she watches on KWKT Fox 44, and many other viewers have also submitted questions like this, and she says, now that our stay-at-home order is lifted, should we visit loved ones in nursing homes? Can they visit us? And this is that vulnerable population you were just talking about. What's your best advice?
Yeah, my best advice, as I think as sobering as this may be, is the vulnerability of nursing homes in our country right now is profound. At least 1/3 of the outbreaks of what we're seeing are in nursing homes. So my recommendation would be at this particular time that you do not try and visit in the nursing homes unless you are absolutely certain that at that time you are not infected. And sometimes it's really difficult to provide that assurances. So the nursing homes are so vulnerable right now where we are in most places. And again, there's variability throughout the country. In most places, I really would try to best as possible preserve the sanctity, as it were, of the cutting off of the interaction in nursing homes. As difficult as it is, to get personal about it, I have a situation just like that in my own family, with my wife's mother who is in an extended care home. Obviously, she'd like to see her mother, but it's very, very difficult to do that.
Yeah, it's one of the many tragedies of the epidemic. There's so many, it's hard to even focus. But you're right, that's, I think, great advice. And turn now to this question, who was sent in by Tracy from Tampa, Florida, and she watches on FLA News, Channel 8. Tracy says, new COVID-19 hotspots are cropping up. Is this something we expected and shouldn't be worried about, or will reopening the country now erase all of our progress over the past few months? What do you think?
Well, Mike, I'm really glad that that individual asked that question, because it is something that we need to look at very seriously. Right now, there is an urge, an understandable urge, to open up the country for both one's own physical and mental well-being, as well as for the economic implications. We have guidelines that have been very clearly delineated about the pace with which you would do that. So let's say a county, a city, or a state is doing it according to the guidelines, and they're pulling back on some of the mitigation. Without a doubt, given that there is still infection to a greater or lesser degree everywhere, we certainly haven't eliminated it, no chance that we've eradicated it, which means as you pull back on mitigation, you will likely see little blips of infection. That's something not to be discouraged by, but you should have in place the manpower, the capability, the program, and the testing to identify, to isolate, and to contact trace. Because it would be incumbent upon us, as those inevitable blips come up, that we prevent them from becoming resurgences. Because if we don't do that, every time you pull back on mitigation and you allow a big resurgence to occur, you'll be setting yourself back, almost resetting the clock. So yes, we do want to tiptoe into opening and getting more freedom. But at the same time, we have to have the capability of responding when you do see infections occur, because they inevitably will occur.
Well, Dr. Fauci, let's stay on the subject of those guidelines. As long as people are following the CDC guidelines, this should help prevent the new hotspots from emerging. However, I doubt the average American is going to comb through that 60-page document the CDC quietly released last week. So what's the best way for Americans to stay on top of these new guidelines?
Yeah. Well, right now, I think the guidelines in their detail, you're right. There are a lot of them. But there are some fundamental principles. And the fundamental principles are to continue, to the extent possible, physical separation, staying away from crowds greater than a certain number, wearing a mask when you are in a situation where you cannot control the distance from one to another, and avoiding crowds. That's where we all should be right now. No matter what phase you're in, you should at least have that fundamental, basic type of mitigation. And I think if we follow that, we'll be okay. You know, it's amazing. If you look at the successful control, be they in other countries or even in our own country, the importance of the simple things that we keep talking about: washing hands frequently, wearing a mask, keeping a physical distance. There are so many things that you can still do and enjoy while you're doing that. So that transcends all the guidelines. Just keep hold of that, and I think we'll be fine.
Tony, let me just ask real quickly just about masks, because they weren't really focused on early on. We were talking mostly about hand washing. So could you briefly explain what a mask does to help people? Maybe that'll help compliance with the mask wearing.
Thanks, Mike, as usual. You asked a real good question right there, because I think there was some inadvertent and innocent miscommunication. And it was playing down wearing masks because it was at a time when we were being almost overwhelmed with cases, and we had shortages of PPE, of N95s, of surgical masks. So we gave the impression, and I think it was an innocent mistake, if you want to call it that, of playing down the concept of the utilization of masks because we didn't want masks to be diverted away from the healthcare workers who desperately needed them for their own protection. Now that we're not in that situation, a mask or a physical covering does two things. If you are infected and you do not know, it would diminish the likelihood that you would spread infection to others. In addition, if someone else is infected and you're not, when you're talking about droplets or even aerosols, you can partially at least block that from coming to you. And this falls under the category, Mike and Art, that I refer to as don't let the perfect be the enemy of the good, because they're not 100% protective. You know, depending upon what study you look at, it's 50, 60, or whatever percent, but it's better than not having a mask. So that's the reason why we are becoming much more enthusiastic about wearing some sort of facial covering. We have a lot of creative ways of doing that. People making their own different colors, add a little levity to it. But wearing a mask is really very important.
Yeah, thanks so much for that, because I think that was really critical. You mentioned testing earlier, Tony. This question was sent in by Kevin from Raleigh, Mississippi, and he watches on WJTV 12 News. And Kevin asked, what is the current status of our nation's testing capacity? Will we ever reach a point where everyone who wants a test needs one in their local area? How are we doing on this?
Mike, we're doing better and better. Obviously, we all know that that was an issue early on with regard to the availability of tests for people who really needed to have tests. Right now, the acceleration of the availability of multiple types of tests and the appropriateness of using one test in one circumstance, like for surveillance, versus another to definitively know if a person suspected of being infected is infected. As the weeks go by and as we enter the late spring and early summer, I think you're going to see a lot of availability of testing that we didn't have before. So I'm not a person who's responsible for the testing, but I listen and hear from the people in the task force who are, and they really assure us that really as the weeks go by, it gets better and better and better. Now, obviously, you're always going to have a person when you ask, did you have a test readily available for you when you needed it? And the answer sometimes might be no, but for the most part, it's marked improvement in the availability and the deployment of testing.
Yeah, we're certainly seeing that here in Alabama, which is welcome. Now we get to have a little fun. We're going to dig into some science here. So this question was sent to us by Shauna from Sioux Falls, South Dakota. She watches in Kellerland News, and many other viewers also submitted questions like this. The question is, how close are we to a COVID-19 vaccine, and why is everyone so reluctant to get to an ETA? And I'll have a follow-up on that.
Okay. So there are a number of vaccine candidates that are at various stages of development. And for example, there's one, and it may not be the best one, but it certainly is the one that's in there first, is one that was developed here in the Vaccine Research Center at the NIH at NIAID. And it's a platform called a messenger RNA. We are well into phase 1 trial. In fact, it's very interesting that it's a nice story, Mike, because and I know you'd appreciate that, and Art too, that the Chinese put the sequence up on a database, public database, on the 10th of January. On the 11th, we took that down, got the gene out, and by the 14th, we had the gene expressed in our messenger RNA system, and we started the development of a vaccine. 62 days later, which breaks all indoor records, we were in a phase 1 trial. We now are well into it. There are 3 doses, 45 people. And what we're seeing right now is that, as was announced a few days ago, the initial immunogenicity data on at least the first 2 and into the 3rd dose is very encouraging for the standpoint of following. Right. We're getting antibody that's not just binding antibody, it's neutralizing antibody. And for those viewing us who know the difference. If this is the part of the virus that you want to block, and this is the business end of the virus, a binding antibody could bind here, and it's almost irrelevant because it's not blocking the virus. A neutralizing antibody binds the business end of the virus and essentially prevents it from replicating and infecting a person. So the levels of antibody are high, the titers are high, even at a modest dose. That's not the end game, but it certainly makes us cautiously optimistic that we're on the right track. And we'll go from phase 1 into a quick phase 2. We're going to probably start a phase 3 for efficacy in the beginning of July, which is really very rapid. And I want people to realize who are listening that the speed of this is not compromising safety, nor is it compromising scientific integrity. The speed is based on the fact that we are doing things at risk. In other words, we're making investments even before we're sure that something will work. And if it works, we've saved a lot of time. If it doesn't, we've lost financial resource investment, which, given the urgency of the situation, we can handle that because we want to go as quickly and as safely as possible, which is the reason why I made the projection in January when we first started the trial that it would take about a year to 18 months to have a vaccine. So a year from January is the end of December. And I think we're probably going to be on target there. The one unknown that you've got to make sure the public understands is that there's no guarantee that the vaccine is going to be effective. Anybody who does vaccines know that's the reason why you do a vaccine trial. But the pace of it and the availability of doses, we feel reasonably confident that we will be on schedule. Let's hope that with good luck and some good science, we have more than one candidate that we can then start distributing in a way that would really put the nail in the coffin of this outbreak.
And that's amazing progress. I mean, you're right. For those who've been involved in vaccine research, this is truly unprecedented. But just very quickly, my understanding, an mRNA vaccine, to get into the weeds a little bit, if it's proven to be effective, is much easier to scale up, correct? So we can get more doses more rapidly, right?
You're absolutely correct. And that was, even though it is not a vaccine that we have a lot of experience with in humans, what the advantages of it are just what you said, Mike, the ability to scale up. But just to be sure, we want multiple shots on goal here. So we have multiple candidates. The NIH is directly involved either by making available our clinical trial networks, Mike, which you know so well since you're such an important part of that. And we're doing something that I think is really good. As Art had mentioned when he introduced you, you're a really major player in the HIV clinical network. What we're doing, Mike, is we're taking the vaccine trial networks, the ACTG, the prevention trial networks, the influenza networks, and we're all gearing them up to be sites to be able to do vaccine for coronavirus. So this is something that's unprecedented, and I think it really is a good sharing of the kind of expertise and resources that we have to do that.
Yeah, and that opportunity came about from years of people working together, and it's great that we can take advantage of it. Transitioning a little bit to therapeutics, we've talked about remdesivir. That's a drug that is an antiviral. It stops the virus from replicating, and work done out of NIAID showed that it is actually effective in terms of shortening the course of illness and showing a hint that it might help with mortality. So this question is from Jimmy in Bakersfield, California, and he watches on KGET17. His question is about remdesivir. And so the question is, how does the government decide how this drug now is distributed? It was transitioned from Gilead to the federal government for distribution in the early phases. So what are the best ways for people to get access to that?
Yeah. So right now, and that's a really good question, because they're obviously, because of the encouraging, though modest, effect of remdesivir and the donation of X numbers of doses by Gilead, the distribution is going to be based right now on really the need of the number of real-time hospitalizations and need for the drug. Because as you well know, Mike, the study that was done that would hopefully going to be published soon was in hospitalized patients with documented pulmonary disease, either by imaging, by oxygenation saturation, or by physical and clinical symptoms. So it isn't been proven yet to be beneficial for people in other situations. So it's going to be distributed, hopefully as equitably as possible, based on the burden of disease and hospitalizations throughout the country.
Yeah, that's great. We're going to transition back to some practical questions. So this is a question from Joanne in Homewood, Alabama, and she watches on CBS 42 News, and she says, my son is signed up for summer camp, and my daughter is starting college in the fall, and I'm worried about another outbreak. Is it safe for camps to be open this summer, or schools to open in the fall? What precautions should we take? And you've already addressed the local epidemics, but any general comments?
Yeah, the general comment, again, gets back to depends on where the camp is, the kind of camp. So let's take the summer first, Mike, and then we'll talk about schools as we enter the end of the summer and the very beginning of the fall. Again, in camps, what one is, I mean, and again, I've spoken with people in different parts of the country. You're going to try and best as possible to diminish the crowded nature of it so that you might have different, if it's a day camp, have some in the morning, some in the afternoon, switch them, try to get them so that they're not in crowded areas, so that there are more than X number of the kids together. Some camps are making sure that actually kids are even tested to be negative before they come in, and then just keep them in the camp, particularly if you have a camp that's an overnight camp where they're living. It's a variety of things from really location to location. Schools is another story, because schools is going to depend, again, on the area in which you're living. And the reason I say that is because when you make a blanket statement, the difference between a school in Wyoming or in Arkansas or in Iowa compared to a school in Chicago or New Orleans or Detroit or New York is going to be very, very different. And I think that what I have been impressed by is the creativity and the commitment of the local officials, with some guidance from the government, of making the right decisions about just how they're going to work the schooling. Are you going to be having morning and afternoon separate so that you can have separation of desks so that you don't have children sitting right next to each other? All of those things right now are under discussion. And I think it's good because they're very productive dialogue about what the best way to do this is.
So Tony, this question is from Michael in Minden, Louisiana, and she watches on KTVE 10 online. And Michael asks this, is the virus likely to be eradicated? And if so, what would the new normal look like? Is it going to be like the old normal? In other words, how does this all end up?
Well, those are good questions, and I'll mention it for the viewers because Mike is totally aware of this. So when you're thinking about viruses, there's control, there's elimination, and there's eradication. So control means you have virus in the community, but you're controlling it at a low enough level that it isn't a public health issue. Elimination is there's still virus on the planet, but you've eliminated from where you are. For example, we've eliminated polio from the United States. We've eliminated smallpox, and we've eliminated, measles, except when people don't get vaccinated. Very few viruses have been eradicated. The big one is smallpox that we've eradicated. So that's an introduction to my direct answer to your question, is that we're not going to eradicate this virus. It is so transmissible that it's going to be around for a while. Can we eliminate it? Likely, if we do it correctly and we get a vaccine. Will we control it? We already, in certain regions, cities, states in this country, are doing that. The new normal will likely be, for at least a cycle or more through seasons, that we will have to have special precautions of things that we likely should have been doing anyway. Washing hands as often as possible, being careful in crowds, wearing a mask if in fact you have a density of infection in the particular physical location where you are. I think this is going to get better and better. The real determining factor to put this into the history books will be if we get a safe and highly effective vaccine. If we do that, we can render this virus somewhere between eradication and elimination. I don't think we're going to eradicate it for the reasons I mentioned, but I certainly think we can eliminate it from certain regions of the world and certainly control it better.
Well, Dr. Fauci, as you talk about the end of it, I want to talk about the beginning of it, and we could talk to you all day long, but this is going to have to be our last question for you. If there's one thing we could have done differently to better prepare for the COVID-19 pandemic, what would it be?
You know, that's a question we always ask ourselves. There are so many things. We have to be humble and realize that, you know, we are imperfect. We try our best to respond appropriately. People always say if we had been more aggressive early on and really shutting down the country in the sense of locking in as we do right now throughout the country, we may have saved a considerable number of infections. That is likely the case, but it really is a who could have or should have or would have. And really, it's not that productive to think that way rather than get our energy to look forward. You could always find something that you could have done better because we're just not perfect, but we've got to do what we can with what we have.
Yeah, I couldn't agree more. I think maybe when this is all over, we can look back and learn lessons, but yeah, I couldn't agree with you more. We need to take this moment, move forward, and get control of the virus until we create a vaccine. Art?
Yeah, it is so good to see these two old friends getting a chance to talk about something that's so important to the entire world right now. So Dr. Fauci, Dr. Sag, we thank you for volunteering your time to clear up the confusion about COVID-19 for our viewers all across America. Information is power and one of our greatest weapons in the fight against this pandemic. We appreciate your service to our country during this unprecedented time in history. So America, if you have a question, if it wasn't answered today, it may be featured on tomorrow's show. You can reach us by messaging your local Nexstar station on social media or by sending an email to coronaquestions@nexstar.tv. And be sure to join us tomorrow, same place, same time, for another special edition of Coronavirus House Calls, fighting a pandemic in the era of information warfare. We'll have this diverse panel of experts, including ER doctors on the front lines, a medic who served in Iraq, a U.S. Army reservist, and a PTSD expert. I'm Art Franklin.
And I'm Dr. Michael Sag.
We thank you for spending part of your Saturday with us. As you can see, we're 6 feet apart as we brought you Coronavirus House Calls. Always wash your hands. Let's take care of each other.
I think that's great advice, Art.
Yeah, definitely, Dr. Sag. Good to have you. Good to have you as well. Have a great day.